Our journey begins with case one. It's a 44-year-old male. He's found stumbling, he's sedated, and he admits to a long history of heavy alcohol abuse. We're talking 6 to 7 beers a day, every single day.
And he says his last drink was about 34 hours ago. So the initial state is sedation, but the real danger is what his body's getting ready to do next.
Right. And the lab work that comes with the case is a big red flag. It shows elevated markers that suggest liver damage, tissue injury. It's a clear sign that this chronic habit has had real physiological consequences.
So even though he's drowsy at first, the most likely diagnosis here is actually alcohol withdrawal.
That's a really crucial distinction to make. In the clinic, you're often looking for those signs of chronic injury. You know, evidence of fatty liver or liver inflammation, which those labs did confirm. But the immediate urgency, the real crisis, is understanding the shift from that chronic sedation to an acute, potentially life-threatening hyperarousal.
And this is where we have to talk about the core mechanism, the gamma-aminobutyric acid system, or GABA.
Exactly. GABA takes center stage here.
So explain for us what alcohol is actually doing to the GABA system when someone's drinking habitually. We often hear GABA called the brain's brake pedal.
That analogy is perfect. It's exactly right. GABA is the primary inhibitory neurotransmitter in your brain. Its job is to tell your neurons to calm down, to stop firing so much.
Okay.
Now, alcohol is an external depressant. It comes in and dramatically enhances that inhibitory effect. It pushes that brake pedal down hard.
So it's basically amplifying the calm down signal.
Way beyond normal levels. And when someone is consuming alcohol repeatedly, chronically, their brain detects this overwhelming constant inhibition. And it compensates. It essentially says, okay, I'm being inhibited way too much, so I'm going to chemically adapt by making my own inhibitory receptors less responsive.
So it desensitizes the GABA receptor.
It desensitizes them. It's
Right.
trying to maintain some semblance of normal neuronal activity in the face of this chemical flood.
So the brain is building a tolerance by basically dulling its own brake system to overcome the alcohol's effect. It's creating this very fragile artificial balance.
Precisely. And that right there explains the profound dangers of withdrawal. When you suddenly stop the alcohol, when you take that chronic inhibitory agent away, well, the brain's internal brake pedal is still dulled, but now there's no external force providing that extra inhibition.
And the whole system just goes into overdrive.
The now hypersensitive compensated nervous system is thrown into what we call hyperarousal. Neurons just start firing uncontrollably because there's nothing left to inhibit them. And that core pathophysiology, that one mechanism, explains every single symptom of withdrawal, from minor tremors all the way to catastrophic seizures and delirium.
And the source material points out that the chaos isn't just limited to GABA, right? Other neurotransmitters get pulled into this.
Oh, absolutely. The levels of norepinephrine, which is a major fight-or-flight hormone, are way up. Serotonin levels are altered. Norepinephrine specifically is what drives that autonomic hyperarousal. It's what's causing the rapid heart rate, the hypertension, the agitation.
So these chemical imbalances are responsible for not just the physical tolerance, but also the intense psychological craving.
We're completely intertwined.
Understanding the symptom timeline here seems like it could be the difference between a minor intervention and a trip to the ICU. How does this whole cascade progress?
It's highly dependent on the half-life of the alcohol and, of course, the degree of chronic use. But generally, it follows a predictable pattern. First, you have the minor symptoms.
Okay.
These usually show up earliest, somewhere within 6 to 36 hours after the last drink. This is where you see the tremors, GI upset, headache, palpitations, that intense feeling of anxiety.
And then it can get worse from there.
It can. As the withdrawal progresses, the risk for seizures, usually the generalized tonic-clonic kind or hallucinations, goes up significantly. This typically happens between 6 and 48 hours.
And with the hallucinations, is the person aware of what's happening?
That's a great question. Often the patient is still conscious and aware that they are hallucinating, which makes them distinct from the true delirium state that comes later. They might see things or hear things, but they know it's not real, which can be terrifying in its own right.
And then after that stage, we hit the life-threatening peak, delirium tremens.
Delirium tremens, or DTs. This is the most severe manifestation. It usually hits around 48 to 96 hours after the last drink, so 2 to 4 days out. DTs are characterized by true delirium, a profound global change in cognition.
So this isn't just seeing things anymore.
No, this is a complete break. It comes with severe agitation and, critically, what we call autonomic instability. This means you see these dramatic, dangerous swings in vital signs: severe tachycardia, hypertension, a low-grade fever, and drenching sweats or diaphoresis.
Now, while DTs are obviously the most dangerous outcome, the sources do thankfully note that the incidence is pretty low. Only about 5% of patients in withdrawal get this far.
That's true, but because of the potential for cardiovascular collapse and hyperthermia from that instability, you have to intervene swiftly and aggressively.
Which means we're bringing back the very system that alcohol shut down in the first place. What's the cornerstone drug for managing this hyperaroused state?
It's benzodiazepines. Specifically, drugs like lorazepam or diazepam are the treatment of choice for all types of alcohol withdrawal symptoms. They are GABA modulators. They effectively step in and restore some of that critical inhibitory function by acting on those same hypersensitive GABA receptors.
So they're basically a substitute brake pedal while the brain's own system recalibrates.
That's a great way to put it. They reduce the runaway neuronal firing and allow the nervous system to slowly and safely return to normal.
It's a fascinating twist that the treatment for alcohol withdrawal, which involves modulating the GABA system, is often the source of another crisis.
Yes, and that brings us right to case 2, which details benzodiazepine toxicity. We have a 24-year-old presenting with blurred vision, confusion, somnolence, and a dangerously shallow respiratory rate of only 8 breaths per minute.
This is a direct example of the central nervous system being, well, overdepressed.
Exactly. And to understand the danger here, we have to look at the structural differences between two major classes of CNS depressants, benzodiazepines and barbiturates. Both are highly effective, and they both target that same GABA receptor to inhibit neuronal firing.
But there is a subtle yet absolutely critical difference in how they do it. And this difference is pretty much the reason one class is still widely used today and the other has been largely retired from primary care.
This is really the aha moment for understanding GABA pharmacology. So remember, the GABA receptor is basically a chloride ion channel. When it gets activated, it opens up, lets negative chloride ions flow in, and that hyperpolarizes the neuron, making it less likely to fire.
The brake pedal.
The brake pedal. Now, benzodiazepines work by increasing the frequency of those chloride channel openings. So think of it like a rapid-fire series of quick inhibitory pulses. It's a much more manageable, controllable effect.
Okay, so it's like tapping the brakes lightly and frequently.
Exactly. Barbiturates, on the other hand, work by increasing the duration of the channel openings. They hold the gate open for a much longer time.
So a barbiturate is slamming the brakes on and keeping the pedal stuck to the floor.
Precisely. The effect is much more profound, it's prolonged, and it's very dose-dependent. And that's why the patient in case 2, who's experiencing toxicity, is showing symptoms of severe CNS depression, including that life-threatening respiratory compromise. The patient is just simply too inhibited to breathe adequately.
Given that risk, is there a simple way to reverse the effects of a benzodiazepine overdose?
Fortunately, yes, there is. We have a drug called flumazenil. It acts as a competitive antagonist at the GABA-A receptor.
Meaning it kicks the benzodiazepine out of the way.
It competes with the benzodiazepine for the same binding site, effectively blocking or reversing the drug's inhibitory effects. It's highly effective in reversing an acute overdose.
And this leads us directly back to that critical safety distinction. Why are benzodiazepines considered so much safer than barbiturates in clinical practice?
It all comes down to a concept called the therapeutic index. That's the difference between the dose you need for a therapeutic effect and the dose that causes toxicity.
The margin of error.
The margin of error, exactly. Because barbiturates cause that profound, prolonged opening of the chloride channel, they have a lower therapeutic index. A very small increase in dose can lead directly to coma and severe respiratory depression.
I see.
Benzodiazepines, by contrast, have a much higher therapeutic index. An overdose is still very serious, as we see in case 2, but it is far less likely to be immediately lethal because the mechanism just isn't as forceful.
We also need to talk about the real-world complications here. I mean, polypharmacy is rampant, and the source material lists several common drugs that can dangerously increase benzodiazepine toxicity through the P450 system.
This is vital. This speaks to the body's complex detoxification system in the liver. The cytochrome P450 enzyme system is responsible for metabolizing a huge number of drugs. And if you take another drug that inhibits those enzymes, the benzodiazepine doesn't get broken down as quickly. The concentration in your bloodstream goes up and toxicity increases.
So what's on that high-risk list?
The big ones are acetaminophen, alcohol, which we already know is a common combination, cimetidine, disulfiram, isoniazid, and valproic acid. Any informed patient or clinician really needs to be aware of these potent interactions.
The complexity of these interactions leads us perfectly to case 8, a 19-year-old college student. He's found drowsy, breathing shallowly, and exhibiting pinpoint pupils.
Right, and when you see that combination, shallow breathing and constricted pupils, especially in a young person, your diagnostic search has to cover a very broad and sometimes conflicting spectrum of different substance classes.
The scenario immediately makes you think opioids.
It does. It strongly suggests opioid intoxication, but relying on a single symptom is incredibly risky. The real challenge in acute clinical science is differentiating intoxication from withdrawal across all these different substance classes, especially when you suspect polysubstance use.
Okay, so let's try to construct that symptom matrix. Let's start with the two great opposites, depressants and stimulants. We know opioids are potent depressants.
Right. So for opioids, heroin, fentanyl, and so on, intoxication presents as intense euphoria, extreme drowsiness, slurred speech, decreased memory, and critically pupil constriction, those pinpoint pupils, and dangerous respiratory depression.
And what does withdrawal look like?
Withdrawal is the complete opposite. The body goes into sympathetic overdrive trying to compensate. The symptoms are just intensely unpleasant: nausea, vomiting, severe diarrhea, muscle aches. But critically, you'll see pupil dilation, mydriasis, and insomnia.
Okay, now let's contrast that with a pure stimulant, like cocaine.
For cocaine or amphetamines, intoxication is a state of severe sympathetic overdrive. We see tachycardia, hypertension, paranoia, extreme agitation, and dilated pupils. The patient is hypervigilant, often aggressive.
And the withdrawal.
The withdrawal from stimulants is less physically dangerous than opioid or alcohol withdrawal. It presents primarily as a profound crash. This is characterized by severe depression, fatigue, increased appetite, and a lot irritability.
So moving back to the GABA-acting drugs, benzodiazepines and barbiturates, what's the clinical snapshot for those?
For intoxication, you're going to see respiratory and cardiac depression, unsteadiness, confusion, and disinhibition. It can look a lot like alcohol intoxication.
And the withdrawal sounds familiar.
The withdrawal is that highly dangerous, hyper-aroused mirror image. You get agitation, tremor, anxiety, delirium, and seizures. It's a picture that's almost identical to severe alcohol withdrawal, and that's because they share that fundamental mechanism of action on the GABA receptor.
Finally, we have the hallucinogens, PCP and LSD. Their presentation is more about the acute psychological state than core vital signs.
Exactly. PCP intoxication is known for this intense, often terrifying psychosis, highly violent, unpredictable behavior, and a specific physical sign called nystagmus, which is involuntary eye movements.
And LSD?
LSD intoxication is primarily sensory. You get visual hallucinations, synesthesia, which is like seeing sounds or tasting colors, and dilated pupils. But here is the really unique detail for LSD.
What's up?
There are no true physical withdrawal symptoms documented. The mechanism of action is primarily on the serotonin system, and the body just doesn't appear to develop the same degree of acute, life-threatening physical dependence that we see with the GABA drugs or opioids.
That is a powerful transition, moving from the neurochemical turmoil in an adult to the complete vulnerability of a newborn infant experiencing withdrawal. Case 13 introduces a newborn, just 35 weeks gestation, presenting only 30 minutes after birth.
And the initial symptoms are classic and terrifying. You have respiratory depression, central nervous system depression, and those telltale pinpoint pupils. This triad just screams acute opioid intoxication from in utero exposure.
So the baby is, in effect, still under the influence of the mother's last dose.
Precisely. So the first priority has to be immediate intervention for that acute intoxication.
What's the treatment?
Without question, the infant needs naloxone. It's an opioid antagonist. Naloxone is a lifesaver in these situations because it acts quickly, it selectively binds to the opioid receptors, and it blocks or reverses the depressant effects, hopefully restoring normal, spontaneous breathing.
But the immediate intoxication, that's only phase 1 of this crisis. By day 3, the picture completely flips from depression to profound hyperactivity. This is neonatal abstinence syndrome, or NAS.
Exactly. The infant, now free of the drug but having developed dependence in the womb, starts exhibiting severe withdrawal symptoms: tachycardia, drenching sweats, tremors, a very high-pitched, inconsolable cry, and severe CNS excitability.
They've gone from being acutely depressed to systemically overstimulated. It's just like the adult opioid withdrawal we just talked about, but it has to be exponentially more dangerous for such a fragile system.
It is. Which is why clinicians need a way to standardize the diagnosis and severity, given how varied the symptoms can be.
And how do they do that?
They use something called the Finnegan scale. This is a validated diagnostic tool that systematically assesses 21 common signs of neonatal drug withdrawal. It covers CNS, respiratory, metabolic, and GI disturbances.
So it gives it an objective score?
It does. And that score is essential not just for determining the severity of the withdrawal, but also for guiding the pharmacological treatment and the whole weaning process.
So speaking of treatment, the long-term management often involves using opioid agonists like methadone. Now, why would you introduce another opioid into an already dependent system?
That's a point that often confuses people. The use of methadone is a very controlled strategy. It's not about prolonging the addiction, it's about relieving the agonizing acute withdrawal symptoms and providing stability to the infant's nervous system.
With the bridge.
It's a bridge. The key is that the dose is carefully managed and must be slowly, methodically tapered as the baby is gradually weaned off. You're replacing the chaos of acute withdrawal with a controlled, safe de-escalation to minimize harm.
And stepping back, we have to remember this case is part of a much larger systemic crisis. After the baby is stabilized, what kind of comprehensive care is required for the mother?
The mother requires long-term, coordinated medical and psychological treatment for her substance abuse. This often means immediate screening for highly prevalent infectious diseases like HIV, hepatitis B, and hepatitis C.
So the health crisis doesn't end at birth.
Not at all. It demands continuous follow-up care and support systems to try and break the cycle of substance use and ensure both the mother and the child are protected long-term. This is really where the clinical science meets a profound societal challenge.
That powerful look at acute crisis brings us to Section 2, where we're going to pivot to long-term disruptions in development. We're going to contrast a state of profound self-disruption anorexia nervosa with the predictable healthy path of pediatric milestones.
We start with case 3. This involves a 16-year-old girl presenting with rapid severe weight loss. Her BMI is down to 17. She has an intense fear of gaining weight, amenorrhea, the loss of menstruation, and bone pain. The diagnosis is anorexia nervosa.
And this diagnosis is about more than just noting the weight loss. We have to understand the cascade of physiological damage it causes. Beyond the fear and the caloric restriction, what are some of the subtle clinical hallmarks that clinicians are looking for?
Well, patients are typically below 85% of their ideal body weight. Beyond the obvious emaciation and intense fear, clinicians are looking for signs of compensatory behaviors. The source material points out something called Russell's sign, which is an indicator of purging.
Describe Russell's sign for us. It's a physical manifestation of a psychological behavior, right?
It is. It refers to calluses or scarring that you find specifically on the knuckles or the back of the hand. This damage happens because of the repeated abrasion of the hand against the teeth during self-induced vomiting.
It's a silent physical tell.
Exactly. A tell that a patient is engaging in purging behaviors, and that repeated purging causes profound damage to the mouth. The chronic exposure of the teeth to stomach acid causes severe dental erosions.
But the damage goes much deeper than that, affecting every system in the body. Let's focus on the skeletal system, which often suffers irreversible harm.
The chronic nutritional deficits lead to severe electrolyte and protein imbalances, like hypocalcemia and hypoproteinemia. But the bone density loss is catastrophic. The lack of adequate fat and calorie intake, combined with hormonal changes, disrupts estrogen levels, leading to significant bone density loss.
So an X-ray might show something unexpected.
It might. It might reveal stress fractures, for example, of the fifth metatarsal bone. This is characteristic of osteopenia or osteoporosis, secondary to vitamin D and calcium deficiency. You're looking at a brittle bone state in a teenager, which is a hidden long-term catastrophe.
We also see hematologic consequences in this case, specifically a low hematocrit and a low mean crepuscular volume, or NCV, of 78.5.
Yeah.
What does that blood picture tell us?
That low MCV suggests a microcytic anemia, which is commonly caused by iron deficiency from not eating enough. However, in these patients, you also have to screen for B12 and folate deficiency, which cause a macrocytic or large cell anemia. Sometimes the patient presents with a mixed picture, where both types are present at the same time, which further complicates the clinical management.
Before we talk about treatment, let's go into the brain, specifically the hypothalamus, which controls our hunger and our sense of fullness. It's a pretty elegant opposing system.
It is remarkably balanced. We have two key regions. First, there's the feeding center, which promotes appetite and drives eating behavior. That's located in the lateral nucleus of the hypothalamus.
And if you stimulate that area,
The person will eat. Then you have the satiety center, which signals the body to stop eating. That's located in the ventromedial nucleus.
then what happens if those areas get damaged?
Lesions to the satiety center, the ventromedial nucleus, cause hyperphagia or excessive eating and lead to obesity. Lesions in the lateral nucleus can cause profound anorexia and a refusal to eat. The brain is literally wired with this complex, finely tuned metabolic balance point, and the disorder of anorexia just fundamentally overrides it.
Given the medical severity, the treatment strategy has to be pretty intense. What's the prognosis like?
The treatment is multidisciplinary and very intensive. The first non-negotiable step is medical stabilization. You have to restore the patient to a healthy weight to reverse those immediate physiological dangers like electrolyte imbalances and cardiac instability.
And that has to be paired with therapy.
Absolutely. Paired with psychotherapy, cognitive behavioral therapy, or family-based therapy to correct the distorted thoughts and behaviors. Unfortunately, the prognosis is variable. The sources say only about 1/5 of patients fully recover. Another fifth remains severely ill, and the remaining 3/5 have this fluctuating chronic course that requires long-term management.
We're going to transition now from that severe self-disruption of anorexia to the expected, predictable path of healthy human development. This is case 10. 15-month-old fraternal twin boys. One is walking, the other is not.
And this scenario highlights the natural variation in development. It's a very common cause of parental anxiety, especially when siblings are compared directly like this.
But the source materials is reassuring on this point.
Very. It is completely normal that one twin has not yet begun to walk. The approximate age for independent walking is 15 months, though the window is usually between 12 and 14 months. But what we really look at is the progression. For example, a child should be able to sit without help by 6 to 9 months, which is a critical precursor to standing and walking.
So to provide some context for everyone listening, let's detail that key motor trajectory from infancy into toddlerhood.
Sure. We can map out the gross motor milestones pretty clearly. You have sitting with support around 6 to 8 months, then cruising, that's walking while holding onto furniture at about 12 months.
Then walking.
Then walking independently, somewhere between 12 and 14 months. After that, you see climbing stairs, which is highly variable, anywhere from 12 to 24 months. Riding a tricycle is a 3-year-old skill, and hopping on one foot is a 4-year-old skill.
So developmental checks are about ensuring the child is hitting these markers within a reasonable window, not on the exact day.
Exactly. It's about the sequence and the general timing.
Now let's look at the primitive neurological functions, the reflexes that are supposed to disappear within the first year as the higher brain centers mature.
These primitive reflexes are fascinating because they tell us about the health of the nervous system pathways, and their disappearance is just as important as the emergence of a new skill.
What are the key ones?
There are 4 key reflexes that should fade within that first year. You have the Moro reflex, which is the startle reflex where the infant extends its limbs. The rooting reflex, which is the essential feeding reflex where the head turns and sucking begins when the cheek is brushed.
Then the grasp.
The palmar reflex, that strong, involuntary grasping of objects in the palm. And finally, the Babinski reflex. This is the fanning out and dorsiflexion of the large toe when you stimulate the sole of the foot. This is normal in infants, but indicates pathology if it persists or reappears in adults, because the nervous system should mature enough to suppress it.
We also need to map the cognitive and language milestones that define this incredibly rapid period of learning.
On the cognitive and social front, a social smile appears around 3 months. The child starts to recognize people specifically around 4 to 5 months. Stranger anxiety and voice orientation turning their head when called emerge between 7 and 9 months. And classic separation anxiety tends to peak right around 15 months, just like our twins in the case.
And language acquisition is maybe the most dramatic leap of all.
It truly is. It starts with cooing at 3 months, moves to complex babbling at 6 months. By 12 months, you expect simple, specific words like mama or dada. And by 15 months, the child should be speaking a few distinct words. Tracking all these combined milestones helps us build a comprehensive picture of neurological and behavioral integration, ensuring the child is progressing along that established healthy path.
Before we leave the newborn stage completely, we have to discuss the APGR score. It's an immediate, critical assessment tool, but Its limitations are often forgotten.
APGR is absolutely critical for triage right there in the delivery room, but its role has to be properly understood. It's an acronym for a scoring system used at 1 minute and 5 minutes after birth.
And it measures 5 things.
5 crucial physiological variables: appearance, which is color; pulse; grimace, which is reflex irritability; activity or muscle tone; and respiration or effort.
And with each category scored from 0 to 2, a 10 is a perfect score. It gives you a really quick assessment of immediate health.
Exactly. It's a measure of immediate neonatal vigor. But, and this is the essential limitation that everyone should remember, the APGAR score is not a prognostic tool for future childhood developmental milestones.
Say that again, because that's a common misconception.
It's not a prognostic tool.
Hmm.
A low score at 1 minute indicates immediate physiological distress, maybe from a difficult birth, and it requires intervention. But it does not predict long-term cognitive or motor impairment. Its job is to tell the clinicians, what does this baby need right now?
We've explored the organic machinery of the body and mind. Now we need to move into the abstract machinery we use to define medical reality. Statistics. This is section 3, where we examine how we measure certainty and what happens when the data doesn't hold up.
Case 9 is a perfect thought experiment for this. Scientists are evaluating a new HIV screening test. It's been administered to 400 people, and we know for a fact that 57 of those 400 people actually have the infection. That's our baseline reality.
Let's define the raw data table, because these 4 numbers underpin everything we're about to calculate. We have 30 people who were true positives, 43 who were false positives, 27 were false negatives, and 300 were true negatives. Now we need to calculate the 4 essential statistical measures of this test's performance.
We begin with sensitivity. Sensitivity answers the question, how good is this test at detecting people who actually have the disease? It's the percentage of infected subjects who test positive.
And the calculation for that is true positives divided by the sum of true positives and false negatives. So that's 30 infected people who are correctly identified divided by the total of 57 infected people.
And that gives us a sensitivity of approximately 52.6%.
Which is terrible.
It's failing spectacularly at the screening stage. This test is missing nearly half of the infected people. Those 27 false negatives are going home believing they are healthy, which is a public health disaster.
Okay, next up is specificity. How good is the test at correctly identifying people who are not infected?
Specificity is calculated as true negatives divided by the sum of true negatives and false positives. So that's 300 non-infected people who were correctly identified as negative divided by the total of 343 non-infected people.
And the result for that is about 87.5%. So the test is actually pretty good at telling healthy people they're healthy.
It is, which brings us to the metrics that truly govern clinical decisions, the predictive values.
Let's start with the one that causes the most distress. The positive predictive value, or PPV. This answers the question, if I get a positive test result, what is the probability that I actually have the infection?
The PPV is true positives divided by the sum of true positives and false positives. That's 30 true positives divided by a total of 73 positive tests.
So 30 divided by 73.
Gives us a PPV of just 41.1%.
Wow, that number is shocking.
It is. If you get a positive result from this test, you only have a little over a 4 in 10 chance of actually having the disease. This test is crying wolf more often than it's delivering a confirmed truth.
So what about the flip side? The negative predictive value, or NPV. If I test negative, what's the probability that I'm truly uninfected?
NPV is true negatives divided by the sum of true negatives and false negatives. So that's 300 divided by 327.
Which gives us an NPV of a solid 91.7%.
So this test is much, much better at providing reassurance to those who test negative than it is at confirming disease in those who test positive.
And this leads us to the fundamental concept that explains that shocking 41.1% PPV.
Yes, and that is prevalence. Prevalence is simply the proportion of people in the total population who actually have the infection. In this case, it's 57 out of your 100, or 14.3%.
So we have a test with decent specificity, 87.5%, that returns a terrible PTV of 41.1%.
Yeah.
What does this teach us about the relationship between these variables?
This is a foundational insight in medical statistics. Positive predictive value is directly proportional to the prevalence of the disease being tested.
So even if a test is great at identifying healthy people,
even if it has excellent specificity, if the disease is rare, if the prevalence is low, the sheer number of false positives can quickly overwhelm the number of true positives. The test is accurate when you don't have the disease, but because the disease is uncommon, most of the positive results you get are just statistical noise, leading to mass false alarms. The statistical environment matters more than the inherent quality of the test itself.
That statistical rigor is completely dependent on the quality of the data, which brings us to case 4, a profoundly flawed study proposal. Researchers are studying a new anti-anxiety drug, but they've sourced all their participants only from local meditation groups.
This scenario is a perfect blueprint of how research can fail before it even begins. We need to define bias first. Bias is any source of error that skews the observed association between the exposure, in this case the drug, and the outcome, which is anxiety reduction.
And if we don't fix the bias, all those carefully calculated PPVs and MPVs are completely meaningless.
Exactly. So analyzing this meditation group scenario, what are the immediate glaring types of bias that invalidate the results?
The sources point out 3.
There are 3 classic flaws baked into this design. First is sampling bias. The subjects are all drawn from a meditation group. They are already engaging in a behavior known to reduce anxiety.
So their baseline is already different.
Their baseline anxiety is likely much lower than the general population this drug is intended for. The results can't be generalized. It's like testing a new running shoe only on Olympic sprinters. Your results won't reflect the average person.
Okay, what's the second flaw?
Selection bias. The subjects in this proposal chose whether they wanted to try the drug or not. They weren't randomly assigned. This completely eliminates your ability to gauge the essential placebo effect and introduces inherent systematic differences between the groups that have nothing to do with the drug itself.
And the third type of bias?
Recall bias. The follow-up is 3 months later, and it relies on patient memory. Participants know the study's goal is anxiety reduction, so they may be motivated to remember that they feel less anxious, or they may have simply forgotten their high anxiety moments from 3 months prior.
That issue of gathering information at the wrong time has another specific name too, doesn't it?
It does. It's called late look bias. This occurs when information or results are gathered only after a separate intervention or development has occurred, which could influence the outcome independently of the study drug. For example, if they only followed up with people who felt better, they'd completely miss the people who dropped out because the drug didn't work for them.
So, how do we fix this? What are the gold standard techniques researchers use to eliminate these sources of error and ensure validity?
The foundation of all good clinical science rests on 2 pillars: placebos and randomization.
Let's break those down.
A placebo control giving a control group an inert substance allows us to separate the pharmacological effect of the drug from the psychological expectation of feeling better. And randomization, randomly assigning subjects, ensures that theoretically any known or unknown confounding factors are evenly distributed between the drug group and the placebo group.
We also hear about the elegance of a crossover study design. How does that work?
A crossover study is the highest form of internal control. In this design, the subject acts as their own control. They receive the drug for a period, and then after a washout period, they receive the placebo, or vice versa. This dramatically reduces individual variability and allows researchers to compare the effect of the intervention directly against the subject's own baseline response.
Finally, let's detail the technique of blinding concealing the treatment allocation, which is crucial for minimizing observer bias.
Blinding is the last line of defense against expectation bias. There are 2 main types. In a single blind study, either the subjects or the researchers assessing them do not know who is in the experimental group.
But the gold standard is double-blind.
Double-blind is the gold standard. In this case, neither the subjects nor the researchers know who is assigned to the experimental group and who has been assigned to the control group. This eliminates subconscious influence from both the person receiving the pill and the person measuring the outcome.
We've established how the body handles chemical stress and how we calculate scientific certainty. Now let's look at the mechanics of the brain under acute and chronic physiological stress, beginning with the acute confusion we often see in the elderly.
Case 7 presents a very common yet dangerous clinical picture. We have a 65-year-old diabetic man. He's on post-operative day 4 after a hip fracture, and he is now acutely confused, inattentive, and unable to remember his wife's name.
And his lab work is off.
It is. The sources noted his abnormal labs, mild hyponatremia, or low sodium, and an elevated BUN to creatinine ratio, which suggests dehydration. These findings aren't the cause of his fracture, but they are very often contributors to his mental state.
They're critical puzzle pieces.
They are. Metabolic disturbances, dehydration, electrolyte imbalances. They all act as stressors on the brain that can precipitate an acute change in mental status. But the most important clinical task here is to differentiate delirium from dementia. This is something that's often misunderstood by the public.
So lay out the key distinctions between the two conditions for us.
The difference really rests on three factors: onset, course, and attention. Delirium is defined by an acute onset. It happens suddenly, over hours or days, and a waxing and waning course. The symptoms fluctuate dramatically throughout the day.
And what's the core cognitive feature?
A severe reduction in attention. The patient simply cannot stay focused, yet typically they remain alert.
And how is that different from dementia?
Dementia is a chronic condition with a gradual onset, taking months or years to develop. The course is generally progressive and stable, not fluctuating wildly. And in the early and middle stages of dementia, the ability to stay focused is largely preserved, but general memory and global cognition are progressively impaired.
Our patient just had surgery. What are the common risk factors that converge in a hospital setting to precipitate delirium?
The brain of an older patient is already vulnerable, so common risks include prolonged hospitalization, unrelieved pain, dehydration, those metabolic disturbances like his low sodium, infection, and critically, the stress imposed by the surgery itself. Anesthesia and the inflammatory response to trauma are huge triggers.
And we have to emphasize the role of medications. There's a high-risk list of drug classes that are notorious for tipping a vulnerable patient into delirium.
They are. They interfere with essential neurotransmitter balance, particularly acetylcholine, which is crucial for attention and memory. The major culprits are opioids, which he was likely on post-surgery, anticholinergic agents, sedative hypnotics, including our familiar benzodiazepines, antihistamine agents, and corticosteroids.
So it's often the cumulative effect.
It's often polypharmacy. The cumulative effect of several of these drugs increases the overall anticholinergic burden and causes the sudden collapse of cognitive function.
So what is the absolute treatment priority here?
The key is not to medicate the confusion away, but to treat the underlying etiology. If his sodium is low, you fix the sodium. If he's on 3 medications from that high-risk list, you stop or reduce the unnecessary ones. The first step is always a thorough medical workup, a medication review, and correcting the physiological contributor.
Now let's explore the architecture of the brain during its regular resting state sleep. Case 15 involves a 9-year-old boy with primary nocturnal enuresis or bedwetting. To understand this disorder, we first have to map the normal sleep cycle.
The sleep cycle is highly structured. We cycle through these stages about every 90 minutes or so. When you're awake with your eyes closed, you have high-frequency alpha waves. If you're actively alert, it's even faster beta waves.
Then you fall asleep.
Then you hit stage 1, which is very light sleep, defined by theta waves. After that is stage 2, which is about 45% of your total sleep time. That's defined by unique EEG patterns called sleep spindles and K complexes.
And then you go deeper.
Then you go into stages 3 and 4. This is the deepest non-REM sleep, often called slow-wave sleep. It's defined by low-frequency, high-amplitude delta waves. This is when it's hardest to wake someone up, and this part comprises about 25% of your total sleep.
And finally, REM sleep.
Finally, REM sleep, rapid eye movement. This is about 25% of your total sleep. It's associated with vivid dreaming and temporary paralysis, or atonia. And paradoxically, the EEG returns to those fast, active beta waves, just like when you're awake.
Now, relating this architecture back to our case, in what specific deep stage does that nocturnal enuresis occur?
Enuresis occurs during stage 4 sleep, the deepest, slow-wave, non-REM stage. The disorder is tied directly to the physiology of deep sleep, which is why it's so difficult to rouse the child during an episode.
And this is fairly common, right?
It's very common. Most girls are dry by age 6 and most boys by age 7.
And the pharmacologic treatment for this deep sleep disorder targets that specific stage.
Absolutely. The drug used is imipramine, which is a tricyclic antidepressant. Its mechanism here is beautifully specific. It works by decreasing the duration of stage 4 sleep. By spending less time in that deepest non-REM stage, the opportunity for the bedwetting to occur is significantly reduced.
Thinking about sleep architecture again, how do key neurotransmitters regulate that essential REM stage?
We can link this back to our earlier discussion. Serotonin and norepinephrine, the neurotransmitters that keep us active and vigilant, are associated with reducing or suppressing REM sleep. Conversely, acetylcholine is the primary driver. It strongly promotes the onset and duration of REM sleep.
And what are the distinct, measurable physiologic changes that happen during REM sleep?
Well, while the muscles are paralyzed, the internal systems are highly active. We see dramatic variability in pulse and respiration, blood pressure rises, and there's a key physiological indicator, penile or clitoral tumescence occurs. It's also important to note that the total percentage of sleep spent in REM naturally decreases from infancy through adulthood.
We also have to address night terrors,
Yeah.
which are often confused with nightmares, but are also tied to this deep sleep architecture.
Night terrors are terrifying, abrupt awakenings from stage 4 sleep, often with screaming or panic. The key differentiator from a nightmare, which happens in REM sleep, is that the person is extremely difficult to rouse, and they generally have no recollection of the event because it didn't happen during a dreaming state.
And the treatment strategy mirrors what we saw with enuresis.
It does. The goal is to shorten that deepest stage of sleep. Benzodiazepines are sometimes used to treat night terrors because, by modulating the GABA system, they effectively shorten stage 4 sleep duration.
Our final look at altered states is Case 14, a 21-year-old man whose studies are being derailed by overwhelming daytime sleepiness, vivid hallucinations, and these sudden onsets of sleep.
The diagnosis is narcolepsy, and this isn't just chronic fatigue, it's a profound disruption of the sleep-wake cycle, and it's defined by a specific cluster of 4 classic signs, the narcolepsy tetrad.
Let's go through those.
First is excessive daytime sleepiness, the uncontrollable urge to sleep at inappropriate times. Second is cataplexy. This is a sudden, transient loss of muscle tone, often triggered by strong emotions like laughter or anger. It can range from mild jaw weakness to total body collapse.
Okay, what are the other two?
The third is sleep paralysis, a temporary but terrifying inability to talk or move right as you're falling asleep or waking up. And fourth, hypnagogic or hypnopompic hallucinations.
Those are the vivid hallucinations.
Vivid, often frightening hallucinations that occur right before falling asleep, that's hypnagogic, or upon waking, which is hypnopompic. The case mentioned him hearing bells ringing, which is a classic symptom of the dream state intruding into wakefulness.
So what is the specific defining feature of narcolepsy when you measure it on an EG?
It's the pathological intrusion of REM sleep. Narcolepsy is uniquely associated with the rapid onset of REM sleep within 10 minutes of falling asleep. A healthy person takes 45 to 90 minutes to get to their first REM cycle. In narcolepsy, REM is just showing up inappropriately.
How is this challenging, debilitating condition managed?
The treatment is comprehensive. Behaviorally, it involves lifestyle management, stress reduction, and scheduled frequent daytime naps. Pharmacologically, we use CNS stimulants like methylphenidate or amphetamine to maintain wakefulness.
And what about for the cataplexy and the hallucinations?
For those REM-related symptoms, we rely on drugs that suppress REM, primarily tricyclic antidepressants or SSRIs like sertraline.
And sertraline's role is particularly interesting because its mechanism targets the sleep architecture itself.
It does. Sertraline, an SSRI, is associated with a specific change. It causes decreased REM latency and decreased stage 4 slow-wave sleep. By manipulating the depth and timing of these stages, we can effectively mitigate the cataplexy and hallucinations that are hallmarks of the disorder.
Finally, we should always rule out the other extremely common sleep comorbidity that can mimic that excessive daytime fatigue.
Sleep apnea. It's a major cause of poor quality sleep, leading to excessive daytime fatigue. It's caused by repetitive airway obstructions, which often present as loud, habitual snoring and gasping for air. You always have to screen for it, especially since obesity and hypertension are common associated conditions.
We transition now into the realm of human relationships, focusing on the legal and moral contracts that govern healthcare. We're moving from neurons to negotiation, starting with the very cornerstone of patient trust.
Case 5 is a stark ethical dilemma. A 27-year-old woman presents with bruises and broken ribs. She claims her boyfriend caused the injury, but she is mentally capable and explicitly asks the physician not to tell the police, her family, or anyone else.
So, since she is a competent adult, the principles of patient autonomy and confidentiality have to govern the physician's actions, even if they suspect foul play.
Precisely. Because the patient is neither a minor nor an elderly patient defined in this context as over 65, her right to confidentiality must be respected under HIPAA. The physician has to honor her autonomy and her privacy.
So should the physician, just out of concern, proactively contact her friends or relatives that she mentioned?
Under no circumstances, doing so would be a clear violation of the principle of autonomy and the HIPAA privacy rule. The physician must not contact family or friends unless the patient gives explicit informed permission. The patient controls her own information.
But we know confidentiality is not absolute. What are the key exceptions that allow or even require a physician to breach this trust?
The main exceptions are mandatory reporting for abuse of minors and the elderly. Beyond that, the exception relies on the physician's professional judgment if a potential harm is self-inflicted or, crucially, threatens others. The responsibility can shift from protecting the patient's privacy to protecting public safety.
And this shift is governed by a very famous legal precedent, the Tarasoff decision. Explain that decision and how it applies here.
The Tarasoff decision established the duty to warn. It requires a physician or mental health professional to directly inform and protect potential identifiable victims from harm that's been threatened by a patient.
So give us an example.
If the woman in our case told the physician, "I have a gun and I'm planning to go home and kill my boyfriend," the physician's duty to inform the identifiable victim, the boyfriend, and to detain the patient would override confidentiality. The threat has to be specific and directed at an identifiable third party.
And beyond violence, physicians also have a mandatory public health duty to report specific, serious infectious diseases.
Yes, the duty to public health overrides individual privacy in cases of contagion risk. The list of diseases that must be reported includes hepatitis A and B, salmonella, shigella, syphilis, measles, mumps, AIDS, rubella, tuberculosis, chickenpox, and gonorrhea. This is a legally mandated balance between patient rights and community safety.
Let's move to case 6, which clarifies the 4 core pillars of medical ethics in the context of a life-saving surgery. A 67-year-old man with unstable angina is offered bypass surgery, but he refuses.
The moment he refuses, assuming he has full mental capacity, the physician's overriding ethical obligation is clear.
And that is?
The physician must adhere to the principle of autonomy. If the patient with full capacity decides he does not want the surgery, the physician must respect and honor the patient's medical choices. A patient has the absolute right to refuse any treatment, even if that refusal leads to his death.
Okay, let's look at the 2 principles often discussed together, beneficence and non-maleficence.
Beneficence means the physician has a fiduciary duty to act in the patient's best interest, so to offer the surgery because it could save his life. Non-maleficence means do no harm. In medicine, we often violate non-maleficence as a means to a better end.
Like a surgeon has to cut the skin.
Exactly. The surgeon has to cut the skin, harm, to heal the heart benefit. But despite the physician's belief in beneficence, the patient's autonomy trumps the desire to help.
And the 4th pillar is justice.
Justice is the requirement to treat all persons fairly, without exception. It governs the equitable distribution of medical resources and ensures that access to care isn't compromised by race, income, or social standing.
So, if the patient does decide to proceed with the surgery, the physician must then obtain informed consent. What are the 4 specific legal requirements for that process?
Informed consent has to be a process, not just a signature on a form. The physician must disclose 1, the specific risks of the procedure, 2, the potential benefits, 3, all available alternatives to the procedure, including doing nothing, and 4, the patient's explicit right to refuse the procedure at any time, even minutes before it starts.
All to ensure the decision is truly informed and autonomous.
Exactly.
Our ethical journey culminates in case 11, moving from the operating table to the courtroom. A 40-year-old woman undergoes liposuction. 3 weeks later, her abdominal skin dimples, and the surgeon refuses to repair it, leading to a malpractice threat.
Malpractice is a civil suit, and it requires the plaintiff to prove 4 fundamental criteria. They're known as the 4 Ds.
Okay, define those 4 Ds for us.
To succeed in a civil malpractice claim, you have to prove all 4. First is duty. A physician-patient relationship existed, establishing a professional duty of care. Second is dereliction. The physician must have breached that duty, meaning they failed to follow the standard of care.
And the other 2?
Third is damage. The patient must have suffered actual demonstrable harm, in this case, the dimpling. And fourth is direct. The harm must be a direct cause of the dereliction of duty.
In the specific context of this dimpling after liposuction, when would grounds for dereliction exist?
Dereliction exists if the dimpling occurred because the physician operated below the established standard of care. Maybe they performed the procedure improperly or failed to provide necessary post-op instructions. However,
Yes.
if dimpling is a recognized and accepted complication of liposuction that can occur even when the procedure is performed perfectly, then dereliction may not apply and the case could fail. The burden of proof is on the patient.
And this is a civil case, so it helps to understand the difference in the burden of proof compared to a criminal case.
In a criminal case, the prosecutor has to prove guilt beyond a reasonable doubt, which is an extremely high standard. Malpractice is a civil tort. The burden of proof relies on establishing a lack of reasonable and ordinary care or skill on the part of the physician. It's a lower threshold, essentially relying on expert testimony that the physician's actions fell below what's generally accepted in the field.
The sources reveal a fascinating insight here. The most common factor leading to litigation is often not the technical error itself.
That's right. The single biggest factor leading patients to sue is overwhelmingly poor communication between the physician and the patient. Misunderstandings, a perceived dismissal of the patient's concerns, arrogance, or a lack of transparency. Those are the emotional catalysts that fuel legal action more than the technical error alone.
So what must the surgeon in Case 11 do immediately, regardless of whether a technical error even occurred?
They have to correct the communication failure. They need to investigate the reason for the dimpling thoroughly. If an error is determined, studies show that an immediate apology and an honest explanation are key to preventing a future suit. The physician has to show empathy and a commitment to correction, recognizing that preserving that patient relationship is often the best defense.
For our final deep dive, we're stepping fully into behavioral psychology. We're going to look at how individuals process conflict and how they learn and adapt their actions based on external stimuli.
Case 12 provides a dense, minute-by-minute behavioral scenario. You have parents arguing, the father, angry at the mother, yells at his 6-year-old son, the son cries, the mother gives him candy to quiet him, the father takes the candy away, and the son throws food across the table. It is a perfect microcosm of defense mechanisms and conditioning in action.
Let's start with the father's initial reaction. He is furious at his wife, but instead of confronting her, he redirects that anger toward his more vulnerable son.
That is the classic textbook definition of displacement. Displacement is characterized by the transfer of feelings, in this case, anger, from one object or person to another who is perceived as less threatening or safer. The father displaces the emotion from the source, the mother, onto the safer target, the child.
And the son's reaction. He's upset by the argument and the directed anger, and he expresses that internal distress by throwing food across the table.
The child is employing a mechanism called acting out. Acting out is the use of extreme, overt, often inappropriate behavior to express a thought or feeling that the child can't articulate verbally or process internally. Instead of saying, I feel powerless and angry because you're fighting, he expresses his distress by throwing his food.
Now we move into the mechanics of learning, starting with the mother and the candy. The child cries, and the mother gives him candy to stop the crying. What conditioning technique is the child accidentally using to control his mother's behavior?
This is a clear example of positive reinforcement. Positive reinforcement occurs when the consequences of a response, in this case, crying, increase the likelihood that the response will happen again.
So the child cries, the mother adds a desirable stimulus, the candy,
And the child learns crying equals reward. The behavior of crying is reinforced and will happen again in the future.
This requires us to clarify the crucial distinction between negative reinforcement and punishment, because those are the most commonly misused terms in everyday language.
This distinction is paramount to behavioral science. You have to remember that both reinforcement, positive and negative, increase the likelihood of a behavior. Punishment decreases the likelihood of a behavior.
Okay, so let's define negative reinforcement.
Negative reinforcement is when a behavior is encouraged by the removal of an aversive stimulus. For example, a mother constantly nags her child to pick up his toys. The nagging is the aversive stimulus. The child picks up the toys to avoid the nagging. The behavior of picking up toys is reinforced.
And punishment.
Punishment is when a behavior is discouraged and reduced by the administration of an aversive stimulus. For example, the mother puts the boy in a timeout because he hit his sister. The timeout is the aversive stimulus administered to stop the hitting behavior.
Finally, we return to the father. He realizes this disastrous conditioning dynamic, and he immediately takes the candy away because the child shouldn't be rewarded for crying. What conditioning method is the father employing by removing that reward?
The father is employing extinction, or non-reinforcement. Extinction is the deliberate elimination of a behavior by non-reinforcement. That is, by removing the reward that was sustaining the behavior.
He's breaking the cycle.
He's breaking the cycle. The child was crying because he expected the positive reinforcement, the candy. By taking the candy away, the father removes the reward, and the child will likely stop crying when he realizes the behavior no longer gets him what he wants. The behavior is extinguished.
We have completed a really comprehensive tour of the human condition in this deep dive. We started by dissecting the rapid neurobiology of the GABA receptor in acute withdrawal, moved through the elegance of the hypothalamus, the balance of developmental milestones.
And we applied cold, calculated statistics to show how even a high-specificity diagnostic test can be a source of mass false alarm if the underlying disease prevalence is low. It's a really counterintuitive point.
And we finished by navigating the high-stakes interplay of legal and medical ethics, from that crucial duty to warn under the Tarasoff decision to the meticulous requirements of proving a breach of duty in a malpractice suit. The sources really reveal that these concepts are all profoundly interlinked.
I think the core takeaway for me is this idea of compensation. The systems we rely on, neuronal, physiological, legal, and behavioral, they're constantly adapting to maintain equilibrium under chronic stress or chronic input.
Which leaves us with a final provocative thought for you, the learner. We saw how the brain compensates for chronic alcohol use by desensitizing those inhibitory GABA receptors. It establishes a new, artificial equilibrium. This idea of systemic compensation for external pressures connects directly to everything we discussed.
Right. How we define a normal developmental timeline, how researchers try to compensate for biases in their data, how ethical frameworks have to compensate for the conflict between individual autonomy and public safety.
So the question to you is, where else in your life, in social structures, your work environment, or your own personal habits, are systems compensating for chronic stress or chronic input? And what will happen, chemically, socially, or behaviorally, when that constant pressure is suddenly removed? That is knowledge you can apply right now.
Thank you for joining us for the deep dive.
We'll see you next time.